So today it's our great pleasure having with us Andreas Teufel, who is a leading person in the hepatological field worldwide. Andreas is very famous for his study on cholestatic liver disease, PSC, PBC, and others. Andreas is full professor of hepatology at the University of Heidelberg, and is also associate member of the medical faculty in Mannheim, the cancer center. He had a long experience in research. He spent 2 years at NIH at Bethesda, and also spent 3 years, I think, on the bioinformatics at the University of Manchester, England. Is coordinating several studies, and is really a pleasure and a privilege for us to be, to be hosting him today when he speaks about cholestatic liver disease, PBC, and PSC. Andrea, the podium is yours. Thank you.
Well, thank you very much for your very kind introduction, and I'm honored to be invited to speak about cholestatic liver disease. I hope you can see my slides.
Yes, you maximize your screen and we are done.
Should work like this, right?
That's fine.
Yeah, so thank you again. The field of cholestatic liver disease is we are very fortunate to have a lot of development in that field, particularly with new drugs and substances in PBC, but also some ideas about PSC that I would like to share with you within the next 30 to 40 minutes. To get everybody on the same page, I would like to summarize quickly PBC. Sorry for the long header agenda here. PBC usually is a chronic advancing disease, which has typically occurring in patients describing itching, cholestasis, elevated liver diseases, and is mostly a coincidental finding in primary care physicians, and then they send it to us and to specialized liver centers for further care. So what is the general natural course of the disease? Usually, as said, patients get referred with elevated liver enzymes, which may have multiple causes. One of the tests that helps to establish the diagnosis of PBC usually is the AMA-M2 antibodies, antimitochondrial antibodies, along with cholestasis or with changes in the bile ducts. Also, we find along the line with the chronic progressing liver disease, increasing liver stiffness, then eventually elevated bilirubin, and then signs of liver cirrhosis, of course, signs of evidence of portal hypertension, and consequences of cirrhosis, being it liver failure, being it esophageal bleedings or cancers. Now, I will touch the issue of treatment in just a second. Without treatment, up to 40% patients will progress to liver transplantation or die within 10 years. So it's, in the end, although we have made significant progress in treatment of the disease, it is a severe liver disease. And in probably 10 years ago, we had many patients on the transplant list. That has fortunately changed, at least to some degree. So the treatment that changed quite something in PBC is the treatment with ursodeoxycholic acid, which has been the first-line treatment now for decades. And a lot of evidence supports the idea that if you treat patients with urso and they respond, meaning almost normalized liver values, they have an almost normal life expectancy. However, if you don't treat patients, or if they don't respond to urso, the survival of these patients is significantly worse. And it is important to note that even an incomplete response to urso is better than untreated patients. So you should, in any case, treat your patients with PBC with urso, and at least in Germany, that works quite well. And I think across the globe, many centers and primary care physicians got the message, and treatment with orso works very, very well. Again, 40% roughly do not respond to orso, and we'll come to that in a second, what to do with these patients then. Now, when it comes to treatment efficacy, and obviously if it's critical that patients have to respond to orso in order to have a almost normal life expectancy, the key question is, how do we measure efficacy in treatment of PBC? And it has become very clear early on that normalization of bilirubin, which are the two upper curves here, that is definitely key to efficacy of orso treatment. A second marker that seems to be important was alkaline phosphatase, ALP, which also significantly improves the outcome if normalized, or at least below twofold on the upper limit of the norm. And that eventually got into quite a number of, scores for efficacy of treatment with orso. And as you see here, some of them are quite complicated. Paris 1 and Paris 2 are probably the ones that are the best evaluated and documented and verified, but they are quite complex. And that is why many of us chose the Toronto criteria, which is simply AP below 1.6 of the upper limit of the norm. It's a very easy to check in your outpatient clinic parameter without any online calculator or anything. So that for a long time was sort of standard of efficacy estimation in PBC. And we have just now seen last year a larger study by Corpechot and his group from France, who showed that even normalization of, so if you have a full normalization, of AP, that you would do even better than below 1.6. So with new drugs, and we'll come to that later, it seems feasible to at least try to normalize liver enzymes in these patients, and it should at least be the goal of treatment if doable. So what are the options in treating patients? Now, these are the EASL guidelines. I added a little bit to that. So obviously, first-line treatment is also, as just said, and it is important to be between 13 and 15 milligrams per kilogram per day, which usually in like a 70 kilogram patients would be 500 milligram tablet in the morning and in the evening. So it's important to kind of try to be within that range. Many of our patients that we get from primary care physician and get one tablet of orso or get something, but not adjusted to the weight. And it seems critical, at least if liver values are not normal, to check if that's really the case, the dosage is adequate here. There is some issue with higher doses. I'll show that later with PSC. You would think if it does not respond well, you could give even more. Also, it doesn't have that much side effects in the end. The thing is that there have been studies that with also 25 milligrams per day, and it seemed to be even worse than the placebo control at the time, and it seemed to have more side effects like long-term run colon cancer development and so on. So please stay within the range of 13-15 milligrams. Don't add more if things are not going into the right direction. So if we have adequate response to orso, everything is sort of fine. We will check our patients. We do it on a 6-month base here in Mannheim, Heidelberg, and do an ultrasound and check your lab values, and everything is fine as long as they stay solidly the same. Now, if we have insufficient response, the discussion is about second-line therapy. And we have several options, fortunately enough, these days. Obeticholic acid is not approved anymore. I'll come to that in a second. Seladelpar and elafibranor as PPAR agonists have just been approved weeks ago in Germany, but I think seladelpar was in January or so approved. And then we have off-label options, fibrates that have the same mechanism basically as seladelpar and elafibranor, but are not approved. And budesonide is to be debated. It did not show an improvement on fibrosis development in a phase 2 trial. That's why I will not touch on fibrosis, on budesonide use in second-line therapy. Now, what are the data on those drugs? First of all, obeticholic acid, which is an FXR agonist, has several advantages in theory, at least. It is working on the bile acid synthesis side, so working on the cholestatic part, but it also has an impact on inflammation in the liver. It turns down inflammation, making things better with sort of the inflammatory part, and it also seems to have an impact on fibrosis progression. So that was all checked in the POISE trial, a large phase 3 trial that compared obeticholic acid 5 milligrams basically and 10 milligrams to a placebo arm, at least for 12 months, and then there was an open label continuous monitoring of patients. And what you see is clearly that the 5 and the 10 milligram arm clearly outperformed the placebo. So that was very clear in terms of serological markers of PBC. Now, the discussion for a long time with PBC is if improvement of serological markers, surrogate markers, really mean in the long-term run that people do survive longer or no need of transplant and so on. And that has not been solved. The FDA at the time of approval of the drug required the company Intercept and Advance at the time to deliver long-term data on outcome of these patients. And to cut a long story short, the company did not deliver these data. I mean, it was COVID times, and they claim it was difficult to get these data. But in the end, I will touch on that on a second. In the end, the approval of the drug was retracted from the European medical agencies. So it's not available anymore, at least in Germany, or just under very, very specific conditions. It is available in Switzerland. I'm not sure about Italy, but I would assume that it's also not available in Italy then these days. Anyways, so there's a it's a critical discussion. Just for the purpose of a full talk, I mean, it was clearly that after initiation of treatment, AP came down in these patients, and also in the long-term extension phase, it stayed low in these patients. But again, it was taken back, the approval from the European medical agencies. And that makes the question, what other options do we have in treatment? And fibrates were used for a longer time in Asia already. So there was quite some experience of using fibrates, which have a favorable mechanism also on the fatty acids part, but also on inflammation in the liver and also on fibrosis development. And it was also the Kopischer group who showed, at least in a larger study, that if you treat patients with PBC with bezafibrate, that instantly the serum levels of AP would go down, and many other markers such as total bilirubin or transaminases would go down. And eventually, there's also an impact. I believe it was not fully as significant, but as you see here, there may be an impact on the development of fibrosis in these patients. Now, the thing was that fibrates were not approved for treatment of patients with PBC, but it still, at least in Germany, became pretty popular since, I mean, they are cheap as compared to obeticholic acid, which was here in Germany, I believe it was like 12,000 euros per quarter, per 3 months. So it was like 60,000 treatment costs per year. So we and many colleagues, at least in patients, that have had low fibrosis, would prescribe fibrates and see how things went. And if values would normalize, we would wait if there was a pressure to get these values down, or you would have F3 fibrosis or even cirrhosis, we would rather turn to obeticholic acid. Just to show you that these data of fibrates have been reproduced also for other fibrates. There was a shortage in between in access to get bezafibrate. Once these data were published, and fenofibrate seems to work just as well. However, the official or the largest study is bezafibrate. That's why we recommend using that for 400 milligrams per day, and it works really nicely. There was discussions about the combinations of OCA and fibrates, which would even more get those surrogate markers down. However, with OCA not being available anymore, I think there's no point of doing that. Now, I've already touched on that. There were safety warnings first in decompensated liver cirrhosis and then in portal hypertension to use OCA, and it's now no need to discuss that anymore, probably because it's retracted from, at least in Europe, from the medical agencies. So fortunately enough, we have for weeks or months now other options available for second-line therapy, which are the PPAR agonists. And just to show you the mechanisms, or give you an overview about the mechanisms of these drugs, we have several subtypes of the receptor, alpha, gamma, and delta. And the drugs that we are talking about is seladelpar as an delta agonist, and elafibranor as an alpha and delta agonist. And these drugs, again, work on fibrosis, but they also work on the inflammation part, they work on the lipid part, and they have an impact on itching and the pruritus part, which in the disease of PBC, that one of the main symptoms of those patients, and not necessarily linked to the height of the liver enzymes, is pruritus. So that is a very welcome effect of these drugs. And by the way, OCA had the side effect of increasing itching, which was probably something that was difficult to handle in these patients. Now, what are the data from the phase 3 trials that are available? Seladelpar, which had a composite endpoint of achieving AP normalization and bilirubin at least decrease. You see it here with seladelpar 10 milligrams, a significant higher number of patients achieved biochemical response, also achieved AP normalization. And the thing that, as I said, is also very exciting to see is that many patients reported an improvement on pruritus of these patients. And even more, and this is data that was just presented at the American Liver Meeting last fall. Since it's a composite endpoint, not all patients achieved both parts of the composite endpoint, but even those patients who did not achieve the full composite endpoint, you would see that many patients still saw a significant change in AP, much more than the placebo arm. So there's still, even if patients don't get the full response to treatment that was asked for in terms of study conditions, you would still see in many patients the significant decrease in AP, which so far we always considered as very fortunate for these patients. This is the subgroup analysis, and you see that for many patients, or for almost most patients, the efficacy of the treatment was given in all these subgroups. Now, one subgroup that is sort of standing out or always has specific considerations is the group of patients with liver cirrhosis, and that was investigated in more detail, particularly for seladelpar. And looking at the efficacy in these patients, I mean, it's a little lower, but it's still significantly higher compared to placebo patients. Now, these are the patients compared to without cirrhosis. And probably most interesting is on the right side here, the side effects among patients with cirrhosis and without cirrhosis. And I mean, there are significantly patients that have some side effects. However, there are very low patients, 11% versus 5 and 6% of patients that have severe side effects. So bottom line, even in patients with, I would believe, compensated liver cirrhosis, seladelpar seems to be safe and effective at the same time. So this is probably in more detail. What were side effects? And you see it's probably here, data were retrieved during COVID times, but there was no difference between cirrhosis and non-cirrhosis. And then we have POTUS, just a little higher compared to patients without cirrhosis, nausea, and then it's very low number of patients, like 11%. Now, there's even more data. I think the example of OCA being rejected or the approval being retracted by the European medical associations probably led to the effect that both companies are now trying to collect data in a real world setting, and all patients that were that were enrolled in these trials on seladelpar were now offered to continue in a documentation in a phase 4 open label study, and to in a long-term run document the efficacy of seladelpar. And just to give you an idea on the subgroup of cirrhosis, that is always pretty important in the real world setting. You would have similar response rates in terms of the composite biochemical response, but also AP normalization. Again, these are all then real world data, and also the AP reduction significantly was demonstrated in these open label trials. And again, liver-related AIs or overall AIs in these patients, only 20% reported severe adverse events. And no. So I think these data from the open label continuous documentation further support the data that were documented within the clinical trials. Now, one question that has always been important, so fibrates and statins don't go well together or may cause complications in terms of muscle necrosis or severe, at least severe trouble in muscles. And this is why, at least in these long-term documentations, the investigators have studied that in more detail and looked at the statins that were given alongside with seladelpar being a PPAR agonist, which works the same signaling pathways as fibrates would do. Now, the first question was, does that sort of the statin use somehow interfere with the efficacy of those drugs? The answer is probably no. In both groups, statin use and no statin use, we saw a significant decrease of total cholesterol, also fatty liver disease markers and triglycerides. So the efficacy is not changing among patients who have statin use. Muscular skeletal pain or even myalgia, fibromyalgia, muscular spasms, with statin use, we did for sure not see an increase in these side effects. So it seems, or you could, at least from a small number of patients, 45 patients with statin use alongside with seladelpar, does not lead to any severe side effects in these patients regarding to muscle or muscle-related side effects. With that, that was seladelpar, which was an isolated delta agonist of PPAR, and we're coming now to elafibranor, who is a delta and alpha agonist that was studied in the ELATIVE trial. That was also positively reported 2 years ago. And again, you see that the biochemical response, which was AP driven, you see a much higher response than the placebo controls here. And no matter what score you used, I showed you the scores that you use for efficacy evaluation in these patients. No matter what score you use, PARIS 1, 2, or other, you are much better using elafibranor than placebo here. The same story when it comes to itching. Patients that are treating with elafibranor have significant improvement of itching over time. This is almost 1 year here. And if you accumulate that, it's a significant decrease in itching in these patients. So seladelpar and elafibranor, you would say they have pretty much similar in terms of efficacy, but also in terms of reducing itching. And you have 2 options that for now would be pretty similar or pretty comparable in their use treating PBC. So with that, what is approved, we have also ursodeoxycholic acid as a first-line therapy. Everything else, by the way, is add-on. So you leave also and just add on the other drugs. OCA, approved in some countries, not in Europe. Switzerland is still available. Seladelpar, elafibranor have just been approved. We have off-label options, bezafibrate, which we prefer, but fenofibrate also works. Budesonide may be an option if you're sort of frustrated with your patient not making improvement. Again, in the phase 2 study that was done, we did not see any improvement of fibrosis development. And then there's a lot to come within the next year. So it's going to be an exciting field. There's a lot of development and studies going on, and it will be, particularly with the IBAT inhibitors, be interesting to see what kind of developments we'll see over the next years. Now, with the increasing number of drugs that are available now, the question is, how good are we doing in treating our patients? And that is data from the UK. I will say up front, I would think there's no data from Germany, but I would for sure think that the situation is pretty much the same that is depicted here, and we probably can discuss Italy later. So what they did is they looked at 120 hospital boards, roughly 9,000 patients, so a huge number of patients for this rare liver disease. 89% women, which is the normal ratio. Most of them were AMA positive, and 81% were under dedicated hepatology service. Now they all got urso, that is pretty consistent, and it reaches 90% or more than 90% of patients treated with urso. But if you look at all the other things that need to be thought through with PBC, so if liver values don't go down, if transaminases are elevated, do we do a liver biopsy? That is only like 75%. Who's considered for second-line therapy? It's not even 50% of these patients. Symptom evaluation. Do we ask for itching? Do we ask for joint pains? To be honest, we never did consistently in Mannheim, and I'm trying to change that now with these data and things that we are seeing. And it seems to be really important because there's a huge burden of symptoms in these patients. Who gets assessed for liver transplantation if needed? It's only 2/3 of the patients. And who gets surveillance for complications of cirrhosis? Only 70%. And interestingly enough, it does not matter if you live closely to a specialized hepatology center or not. These numbers, they are evenly distributed throughout the country. And again, I would probably think it's the same in Germany from my experience. And everybody I have spoken with in Germany would probably agree that we have a similar situation that patients get also quickly, but then they don't really get looked at if they need the more specialized second-line treatment. And that's probably something we altogether should change. And the reason is, and that is sort of a hard to digest graph, but the reason is it doesn't matter if in the first line, second line, or third line treatment, you get normalizing data. The curves significantly improve and patients have an almost normal life expectancy if you achieve normalization of your liver values. And if you don't, life is probably shorter for most patients, or they need liver transplantation in the end. So with that, I would like to briefly touch PSC as well. PSC is also certainly chronic cholestatic liver disease. In contrast to PBC, it also affects the extrahepatic bile ducts. PBC is only the intrahepatic bile ducts. It is also a rare disease, but in contrast to PBC, there's a little more males affected by the disease. In women, it's 90. In PBC, it's 90% women. And if you look at the ESCP, you see these typical nodule-like bile ducts deformations that are typically for PSC. Now, the prevalence is reported to increase over the past 20 years. It is unclear. I would think that is because we do have more MRIs available. There's more awareness for autoimmune liver disease, and something you would probably not have diagnosed with pure ultrasound 20 years ago is now easily diagnosable in MRI. So in any case, we have more patients in the end that need treatment for PSC. It is important to note that PSC, the prognosis is very much dependent on symptoms. So there is an issue of if symptoms may be reason enough to increase the aggressiveness of treatment. If you have asymptomatic patients, sorry, it's kind of jumping here, they have a much better life expectancy in compared to patients that are symptomatic. Also, bilirubin, that is a significant marker for the prognosis of these patients. If bilirubin is normal, their life expectancy is much better than compared to patients that have a bilirubin longer than 3 months. And finally, that was also just presented last year's EASL. The stiffness, I mean, that is not surprising that fibrosis, the grade of fibrosis is also an important prognostic factor. The more fibrosis, the worse is the outcome of these patients. And finally, and that is probably more important for the IBD side of the story, patients that have PSC and IBD also have a worse prognosis than patients without IBD. We do know that PSC is very, very often associated with IBD, particularly colitis ulcerosa. On the other side around, there was also interesting and also presented on last year's EASL. Also, the course of disease of IBD is worse in patients that have PSC as compared to IBD patients without PSC. Now, what are the treatment options? And to cut a long story short, we don't have too many treatment options. One treatment option that is important, though, is endoscopic evaluation and treatment of dominant stenosis. And the reason is known for a long time. Patients with no dominant stenosis, sorry for that, have a much better prognosis as compared to patients that do have a dominant stenosis. And so what can be done has been studied quite some time in Heidelberg from our colleagues in the Heidelberg University Hospital. And what they have done, they have not only waited until patients with a dominant stenosis had a cholangitis again, but rather they have been scheduled ERCPs every year in these patients. And what they found is that patients that had a dominant stricture and after diagnosing dominant stricture and sort of, re-evaluating the situation with ERCP every year, patients had a significantly better survival. And this was for a few years was noted by the community, but it gets now really interesting because the group from Berlin around Frank Tucker has done the same thing over again and found the same thing. So if you have dominant stenosis and you do ERCP, you do scheduled ERCP and look for this stenosis and try to solve the stenosis situation in ERCP, patients have a much better survival, depending, and no matter if you look at from first diagnosis of the stenosis or even from first diagnosis of the disease itself. So I mean, it's not fully recommended by the guidelines right now, but I think there's at least accumulating evidence to discuss that issue, and we are about to change that in our daily routine, that we're trying with patients with dominant stenosis to schedule them on a regular basis and not wait until cholangitis is diagnosed again. Now, what is the treatment option? Also, that is a long story. Should you rather stent the stenosis, or should you do balloon dilatation? And the answer is, if possible, you should go for the balloon dilatation, not because it's much more effective, but you had there were less side effects, severe side effects documented in these patients. I'll probably skip on that. And this is the story that I've been discussing with you earlier. If you treat these patients with urso and go to high dose, which was tried in PSC, because at the time people thought it may be just a matter of not enough dosage, you see that urso treated patients had a significantly worse outcome than placebo treated patients. And on top, they even had a higher number of colon carcinoma detected. Now, what's the situation with recommendations for urso therapy? The guidelines are very, very diverse. Not sure about the recommendations in Italy. The American guideline recommends against the use of urso. The Asian guidelines kind of recommend doing it, and the European guidelines and also the German guidelines say you can do it sort of in between. To be honest, we usually do it. We give these patients urso, but the effect of doing so remains at least controversial. There's one interesting aspect in terms of treating patients with urso, which is not the improvement of the PSC per se. So that's a larger Japanese study. But what they showed, and what I think is the most interesting part about this study, is that the occurrence of cholangiocellular carcinoma, sorry for that, is much lower in patients that are treated with urso as compared to those are not treated with urso. And with that, I would like to summarize PBC first. Urso is a standard first-line treatment and significantly improves transplant-free survival. AP normalization seems to be a treatment goal. Bilirubins should be normalized as well. FXR seem to be effective in terms of surrogate markers of the disease. We don't really know about long-term effects, and that's why EMA retracted the approval. The fibrates are effective. They are not formally approved, and we have drugs that PPAR agonists that work the same pathway. They are now approved, but they come, at least in Germany, with a significant cost also. Elafibranor is also roughly 50,000 per year. And normalization in second and third lines treatment will still be associated with a high efficacy with respect to transplant-free survival. And in PSC, I showed you that therapy with urso is controversial. We have an increasing evidence. Let's be careful about that, but still, I think it's accumulating that ERCP, scheduled ERCP in the presence of dominant stenosis may be an interesting concept. Also may be effective in Asian patients. Data are changing or discriminative between Asian and Western cohorts, but for sure the co-occurrence of IBD and PSC is associated with a worse prognosis for both PSC and IBD. With that, thank you very much for your attention, and I'll be happy to discuss these data with you. And I'm also very interested in the Italian perspective of cholestatic liver disease. Thank you very much.
Well, thank you very much, Andreas. So this was a wonderful lecture, very highlighting and stimulating.